CIPACA talks only about ICU, isn't it? Second thing, CIPACA is not going to a rural place where we build building, take permissions, haul infrastructure, and then start an ICU. We had done that. That's a traditional way of doing, where we also maybe have to charge more on patients. Whereas what we are doing is shop in shop model. We go and operate in somebody else's place. That hospital is already been built for years. He has already got the infrastructure required for ICU. They have difficulty in managing the ICU, operating the ICU. That's what CIPACA is doing. So we are cutting down the cost of the whole, setting up of ICU to very minimum level. We also actually suggest guide hospitals on getting the infrastructure for ICU. We are very cost conscious. We really tell our partners not to spend more, because the more you spend more for any reason, ultimately who has to pay that? Patient, no? So if you build an organization in such a way that you reduce your cost on capital, which is capex, and also operational, which is OPEX, and then you completely sit only on one thing, providing high quality of ICU care with bare minimum cost. Okay. And when an organization like CIPACA, which has accumulated more than 1 crore hours of handling such things, it is their, I would say, area of excellence. And also, I would say that is their secret formula. Simple. So that is how it is possible for CIPACA to provide the same level of care that is available in cities when you take an ICU in rural places also. Another way of looking at it is like this. So I told about cost. Now you may ask, how do you ensure the quality? Now I am going to ask, what is quality? How do you measure quality of ICU care? Is it just based on the doctors who are working? Is it that a senior most doctor, if he is in the ICU, is it that ICU will have highest level of quality? If you have senior most nurse working in ICU, do you have highest quality? No. ICU is a teamwork. The quality of ICU is defined as quality indicators. What is the survival rate? What are the ventilator days? What is the infection rate? VAP rate? CRBSA rate? Okay, COTI rate? What are the number of falls? What are the number of bed sores happening? What is my reintubation rate? Okay, so these are the things. Similarly, when a patient is received, how fast is the team able to diagnose the physiology of the patient? For example, fluid resuscitation, simplest thing. How fast are they going to assess, maybe with bedside ultrasound, and then are going to ensure that patient is resuscitated properly? How fast are you going to stabilize the patient? If this is the same like in city hospital, both are following the same international guideline. Everybody follows only one guideline. No? It is about implementation that matters. If CIPACA ICU has got the same implementation policies, they follow the same processes, they do the same timelines for everything, how does the quality differ? Okay, even if you want to check, these are all input parameters. What I told is input. I mean, how fast I am going to treat the patient. What is the output parameter? What is my survival rate? As I told you, what is my infection rate? What is my intubation, reintubation rate? Things like that. When you look into all these things, when they are the same, don't you think the quality of care is the same? So it is quite possible to provide the standardized ICU care across hospitals if you follow the processes properly. Also, it is possible to cut cost and provide ICU care even 1/4 of the cost of city hospitals, is because your overheads are less. That is how, combining these two, CIPACA is able to provide the city quality of ICU care maybe for 1/4 cost.